both of us should have equal opportunities.
So there's no merit at all.
Employment is based on merit is one familiar phrase for many institutions, both government and private. But many times, even a careless examination of the practice on the ground tells a story that is completely different to the talk. Sometimes the very systems that should have been positioned to complement the theory seem to be shooting it down instead. Such is currently the case in Malawi's healthcare system, where certain disciplines enjoy some privileges which other cadres cannot, regardless of how deserving they may be.
Doctors and nurses, I think they are not given equal opportunities.
Leadership and supervisory roles in the health sector are mainly offered to medical doctors, sidelining every other cadre.
Mostly we are being kept under the lower cadres and then somebody is leading us.
At the health center level, more qualified personnel are supervised by less qualified personnel simply because the latter do not belong to the medical fraternity.
So it happens that a nurse in charge might have a higher qualification than the facility in charge, but the structure enforces the clinical people to be in charge regardless of having a nurse having a higher qualification than the in charge at the facility.
You will see that the one who is supervising the implementation of policies at the health center level is somebody whose orientation and qualification is lower than a nurse, a midwife technician who is working there. You will find a medical assistant who's gone to school for 24 months, coming out with a certificate in clinical medicine, is supervising the implementation of policies. So when we're talking of policies, we're talking of what is supposed to be done in terms of healthcare services, supervision of human resources for health. It means everybody, including those that have a higher qualification, are being supervised and supported by a medical assistant. So there's no merit at all. So you find a nursing midwifery technician, NMT, who has a college diploma, 36 months, that's 3 years training, and then is supervised and supported by a medical assistant who only went for 24 months.
Circumstances are more or less like the same at the district hospital level. Among other things, nurses and midwives think it would help to have the position of chief nursing officer.
We've seen that in the districts, health offices, we've got like chief medical officers, but in the nursing profession, we lack the chief nursing officers in the district. So we feel also that if we could have chief nursing officers in the district, it would also be a very good platform for the profession at district level, because that will be like our link to the high people that are making policies and all those things that are to support nursing.
We are at council level. The maximum right now is the principal nursing officer, which is now called the district nursing and midwifery officer. And then we are here, the senior nursing officers, of which I'm saying we are 3. So I was thinking if we had maybe the post of the chief nursing officer at the district level, and have the principal nursing officers, maybe I saw maybe 3 posts Then have the senior nursing officers, maybe 5 posts, so that each and every unit should have its own matron. Then in that way, we are increasing opportunities.
Another remarkable grey area at the district hospital level is the position of District Health and Social Services, DHSS, which in previous years was known as District Health Office, DHO.
Let's go to a district facility. You will find that at local councils, the appointment of DHSS, is a standalone leadership position, which in my view is supposed to be assigned on merit. It's supposed to be filled on merit, based on qualifications, based on experience, based on the confidence that somebody has to supervise others and supervise the implementation of health policies. But you will find that when even if a nurse who has a master's degree is a specialist in that field of midwifery, in that field of management, in that field of pediatrics, in that field of adult health nursing, in that field of community health nursing, is put aside. And then somebody coming with the first degrees, MBBS, then is assigned to supervise what I'm talking about here, healthcare policies, including supervision of human resources.
When it comes to central hospitals, out of the 5 that are there, of which 4 are purely curative, there is not even one which is headed by a nurse.
Currently, there is no central hospital that is headed by a nurse or a midwife in terms of what we are talking about, the healthcare services, healthcare service delivery at a central level. In as much as you may have, again, like I mentioned, somebody even at a level of a PhD, we have as at now some nurses, midwives with PhDs working in central hospitals, but they're not given the opportunity, they're not given the tasks, they're not given the responsibility to lead or to head a central hospital, and equally offer those supervisory roles to those that work in central hospitals, supervisory roles in the implementation of service delivery, supervisory roles in all angles of the facility.
At ministry level, the only position that nurses and midwives have the liberty to occupy is that of the Director of Nursing and Midwifery Services and its deputization. This is proportionally out of at least 10 directorates which are related to health.
If you check the system the way it is now, most of the departments at the ministry level are being led by doctors. For example, call it the improvement, where previous years we used to do infection prevention, and then it has been combined. When you look at the issues that are happening, mostly they are nursing issues. But the top leader is the medical officer, who doesn't know the majority of the things that happen. And most of the times, it's us who do the things on the ground, and then they just get the feedback and do the things on the managerial level.
As at now, this year of 2022, so far, it is only one directorate that we have all that independent contribution, if you like, that we can happily say we have a nurse, a midwife, who is a director at a directorate level in the Ministry of Health, and that's the Directorate of Nursing and Midwifery Services, which belongs to nurses and midwives. So it is difficult for this directorate to go to any other cadre or to anybody else of a different orientation.
The Reproductive Health Directorate is also headed by a nurse. Unfortunately, this may soon be an old story in the face of the retirement of the nurse.
I also know we have the RHD, Reproductive Health Directorate, which is currently headed by a nurse, but this nurse is retiring by next year, 2023, and the stake is there, that the directorate is going, strategically to make sure that nurses are not given any further opportunity in these leadership responsibilities. she is being deputized by our colleague from the medical orientation. So it is obvious, unless we protest, it is obvious that, she's been more or less like mentoring, she's been grooming, somebody from the other orientation, and then this directorate means it is going as well.
Nurses and midwives in the sector also know not a thing as automatic promotion. This happens notwithstanding the fact that many have worked for a long time.
We've got a number of nurses who've worked in the ministry for so long, but have never got that chance of being promoted. So we feel that it is also important that the government should be looking into those issues, that they should be considering those nurses that maybe they've worked for so long, they've been committed, maybe ever since they graduated, they've been working for the government. So those nurses need to be picked up and being promoted as part of the motivation.
We have some nurses right now who have been on the same position for almost 10 years without any promotion.
Even upgrading does not break the iron grip of the system to allow that nurses and midwives should be promoted.
When someone goes to health institution for further training, for example, if he comes out from that training institution with, for example, master's degree, for the nursing section it takes time for, or maybe not, they don't, the nursing section does not recognize that qualification until maybe you have been given an opportunity to get a promotional interview. Otherwise, when you get that master's degree, you are not considered at all for promotion, automatic promotion. But I understand in other health professionals, other disciplines, they are considered.
Oftentimes, they have to continue working on the same lower grade that they were on before upgrading. This is contrary to the Malawi Public Service regulations, which stipulate that a civil servant should be promoted every other 4 years.
It's a public tool that government uses, which prescribes that somebody needs to shift in terms of grades and positions. That's through promotions every 4 years. But this is not being done, so people are not being promoted. And worse still, when nurses, midwives come, from upgrading their competences, their skills, themselves in totality. When they come back from schools, they start from where they left as a grade and a position. There's no corresponding promotion that somebody has come from studies, that somebody went for masters. When she comes back, if it was grade I, professional officer, PO, we'll start all over again from that position. And works up until she is frustrated, up until she quits, be it constructively or physically, going because of frustrations.
One would be tempted to think that perhaps it's their education that makes nurses and midwives lose out on leadership and supervisory opportunities. Are they trained well enough to take such responsibilities?
According to the way the curriculum was structured, I think it gives us a basic knowledge on how to be a leader. Because, for example, most leadership and management course is taught at university diploma level, like the nurses that are trained at Malawi College of Health Sciences, as well as at university level, nurses that are trained in Kamuzu College of Nursing, the Young, or Catholic University. It's one of the curriculums. So the basic knowledge that is there, and all the theories that are applied and trained in the curriculum, I think they prepare someone very well to be a leader.
They are well prepared, be it from theory, blocks that they go through, be it in the clinical setup when they are doing their clinical placements in training, pre-service, post-grads. they are equally prepared and very well prepared to head, to lead, to supervise, to coordinate, to plan for the healthcare delivery system at all levels.
Dr. Mandayachepa Nyando, senior lecturer at the Kamuzu College of Health Sciences, KUHES, thinks this is something that can be stopped.
This should stop. People are equally educated, and you see most of these doctors are taking positions. They have got a basic degree, and yet nurses are there with well-qualified masters, PhD, so many of them. Why not give them a chance to lead? And they will lead very well, because I've had it, and I've given examples of that effect already. So yes, nurses are well prepared. Not only nurses, even other cadres, pharmacists, well prepared. Laboratory technicians, well prepared. Public health officers, well prepared. Why just giving to one person to lead? And actually, they are denying patients to be given quality services because they want to rush into a position of leadership. They run away from the bedside. They they all rush to be DHOs. The individual is just qualified. 1 year, 2 years, becomes a DHO. No experience. No experience at all. And there are these clinical officers who have worked for so many years, and they're able, and they were DHOs before, and the hospitals were running properly. Why only now? At one point, Minister of Health should wake up from the slumber. They should not favor one cadre. There are so many. The hospitals, health sector cannot only be run by one cadre. No, it cannot. Give equal opportunities to everybody. Nurses, clinicians are well prepared.
It is not clear why things happen like this, but this is a culture which is believed and adhered to by many.
Nurses are not understood in our culture because they feel that the doctors are more superior than nurses.
Some believe that this has its roots in the Samunda eras when there used to be white doctors. These doctors used to pick unskilled labor from the communities to nurse the sick in the hospitals. But with the passage of time, nurses and midwives have become more and more skilled since the days when late Dr. Hastings Kamuzubanda upgraded nursing to tertiary education level. It is also claimed that there is a memorandum of understanding between the Medical Council of Malawi and the government requiring that only those from the medical orientation should be given automatic promotions.
Unlike the other cadres, when somebody goes for masters, for instance, comes back, it is automatic, and we claim there is a memorandum of understanding between this cadre, the medical, I will put it precisely, the medical council and the ministry. When somebody goes, with a MBBS, goes to school, comes back with a specialization after 3 years, she is automatically shifted from what used to be his entry grade of P8, senior medical officer, to a consultant, and then somebody progresses. So there is a claim that there's an MOU, a memorandum of understanding, which is not there written for the other cadres, nurses, midwives, environmental, pharmacy, etc. Cadres there. But it is not yet fully established whether this memorandum of understanding is truly there, or there is that culture that came in from these traditions of who prescribes becomes a leader at any other time. This culture that the one who mans a facility needs to be promoted, instantly, things like those. We are yet to establish that.
Simeza also thinks that one of the causes of this culture is a clause which may have been wrongly interpreted, found in the Medical Council Act.
Those of us that have read the Medical Council Act, there is a statement that all health facilities are meant to be regulated by the Medical Council of Malawi. So all hospitals are regulated by the Medical Council of Malawi. Nurses and Doctors Council have a tool just to go and assess the eligibility of a facility that can provide services, can support the training of nurses and midwives, it ends there. So because of that, I suppose, prescription in the statutes of the Medical Council Act, it is presumed that by virtue of a facility being under the Medical Council, meaning that all hospitals should be headed by somebody from the medical orientation, from the medical background. It is something that I think, in my view, it should be rethought, to be reviewed in terms of thinking and putting things in that way. It is not equal, to mean that because Medical Council regulates and registers all hospitals here in Malawi, it means all hospitals should be headed by those that come from the medical orientation. I don't think that is equal. I don't think it is the meaning altogether. So what has happened, people might have picked it from there. I heard somebody senior in the ministry indicating, because of the issues of prescriptions. So traditionally, those that prescribe are supposed to be heads of the hospitals, which is not correct and true, and I want it to be edited. If it's only a thinking, then the thinking should be edited. If it is something that is prescribed and written down, that should be edited, because we have our colleagues that have done pharmacy, well qualifying to become directors. We have colleagues that have done laboratory technology. We have laboratory technologists that can equally, lead and supervise others at our district hospital. We have, we're putting it, nurses, midwives, even more qualifying than those that are currently supervising at local level. So we need to move with the time and not the situation and status quo that is at hand now, that has brought a lot of misery, a lot of stresses, a lot of emotions, a lot of constructive resignations amongst nurses and midwives.
This apparently leaves many wondering how, in the day of the dazzling brilliance of the talk of merit, democracy and human rights, there is still biasness, oppression, and no merit among classes said to be the most refined of the nation. In recent years, others have gone as far as creating campaigns aimed at preventing nurses and midwives from leading.
And there's a statement that I would want to brush out and should go, immediately and shouldn't be lingering around. Is this our predecessors who said nurses should not read? That statement, is as painful as nobody can imagine. Somebody as a leader saying nurses should not lead. Then people assemble and create a campaign. So there's no nurses shall lead campaign, And the whole of somebody who's going to school, prescribing, bowing down, drooping as low as that, saying this cadre should not lead, but us. That challenges the kind of leaders we have, and that has posed a huge challenge that the current leadership in the Ministry of Health is unable, very much failing to reverse up until somebody plans to be headed, because the medical team will head somebody who's going to reverse that decision, who is going to reverse that campaign and, give the ground flat for all cadres to be tasked to supervise policy implementation, policy development in the Ministry of Health and other industries.
The policy makers should look at the policies that govern the nursing section and also policies that govern the clinical side section, so that both of us should have equal opportunities.
The potential is there, the future is there. All we need is somebody who is determined to make some of the reverses that our predecessors, I'll put it because it is collective, it is a family of health industry, that our predecessors set as principles, if you like, as abstract policies, if you like, as verbal or personal institutes, if you like, that only this should be leading, not this and not that. That should be edited.